Hello, everyone. My name is Makoto Mori. I'm an associate editor at JACC. Today we have Dr. John Forrest with us discussing about the paper that is going to be simultaneously published at the ACC on the 5-year outcome of Evolute to low-risk trial. Dr. Forrest is a professor of medicine at Yale School of Medicine and the director of the Structural Heart Disease Program. Dr. Forrest, thank you very much for joining us today.
Thanks so much for having me. Appreciate being here.
So we were very excited to receive this important report. And for the reviewers who are not in the structural space, could you contextualize this trial and the landscape of aortic valve replacement?
Yeah, of course. Aortic valve replacement over the past 10 years, 10 to 15 years, has really undergone a transformative change. And that's came along with the advent of transcatheter aortic valve replacement, which first was really designed for patients who were poor surgical candidates. But the success of TAVR in those patients resulted in the idea that, maybe this should be used for patients even who are good surgical candidates. And so the most sort of pivotal studies that have been done in patients who are good surgical candidates are the low-risk TAVR studies. And this study in particular, looking at the self-expanding Evolute platform, took patients who were low risk for surgery. There was no age cutoff in this. There were anatomic exclusion. For example, bicuspid valves weren't allowed. And so often when you have quite young patients, they have bicuspid valves. So this was looking at tricuspid aortic stenosis in patients who were low surgical risk. I think the other important thing, and this is the 5-year results, the other important thing about data like this is that we know patients do really, really well in the short term with a transcatheter aortic valve replacement. The procedure's less invasive, and we know the immediate results are excellent. But what remains a little bit unknown is what are the longer term results. And especially in these studies where these are lower risk patients, it becomes more important data. In the initial studies, the average patients were 80, 85 years old, and you just don't expect an 85-year-old with significant cardiac disease to live another 5 or 10 years. But in these low-risk patients, we do expect a really good percentage of them to live a longer period of time, and how well these valves hold up over time is going to be really important.
Thank you very much, which is a very nice segue to the next question. So Evolute low-risk trial is certainly an important landmark trial. There has been interval publication of the outcomes. So what makes the 5-year mark particularly special?
I don't know if the 5-year mark becomes particularly special beyond the fact that, we sort of like to divide things in 5, 10, 15. But so I actually think it's important that we look all around here. One could make the argument that, 6, 7, 10 years at this point may be a little bit more important than 5 years, but 5 years is what we have here. And so that's why, we're, publishing the data and doing a little bit of a deeper analysis than we have, say, at 4 years, where we really just said, okay, if we look at all-cause mortality or major stroke, which were the primary endpoints from the study, what are those? It takes time, it takes resources to do in-depth analysis constantly. And so I think you sort of pick your time frames where you're going to do that. And 5 years is one that was, predetermined within this to say, okay, let's really look through the data. Let's not just look at our primary endpoint, which we had done at 4 years, but let's look at all sorts of things. Let's understand how they're impacting patients now out to 5 years.
I see. Thank you very much. I think there was initially the publication of short-term outcomes. And I hear a lot of people saying that we really have to see at least 5 years. I think this is a very important data. So could you describe the main findings of this 5-year data?
Yes. So, I think the findings can really be divided into how are the patients doing, and then also like how is the valve performing, right? And so both of them are important. I think obviously first and foremost is how are the patients doing? I think that's the primary thing that you want to see here. And what this data has shown is that out to 5 years, patients who are treated with a transcatheter valve replacement with the Evolut platform here, self-expanding supraannular valve, versus patients who are treated with a transcatheter platform. They perform similarly. Numerically, the patients who get a TAVR tended to do a little bit better in terms of a lot of the main outcomes, but there was no statistical difference between those. And in fact, if you look at sort of the curves between how are patients doing between, from 12 months out to 5 years, it's very, very similar. There are sort of some little ups and downs along the way, but you look at the separation of the curves at 12 months and then look at the separation of the curves at 5 years, it's very similar.
I see. Thank you very much. So I think it seems like to me the main takeaway was that at this 5-year mark, the outcome is still durable in terms of comparative effectiveness of TAVR and SAVR. Is that their takeaway?
Yeah, that's, it's absolutely what we saw. We see when we look sort of across the board, if we look at mortality, we look at cardiovascular mortality, we look at non-cardiovascular mortality, we look at things like disabling stroke, we see sort of consistent performance there. There's if you look at, for example, at non-cardiovascular mortality, they're almost identical, the two groups. Non-cardiovascular mortality was 6.8% in the patients who got a TAVR and 6.2% in the patients who got surgery. So dying from non-cardiac issues, you'd expect them to be pretty similar. Cardiovascular mortality was 7.2% in the patients who had a TAVR and 9.3% in the patients who had surgery. Statistically, not significantly different there, but there was an early separation of the curves that occurred, prior to 1 year, and that's continued out as you look at things like cardiovascular mortality. I think it's important, things like stroke and other things, that we're not seeing a signal that there's any increased changes as these valves age there, and we don't see any of that at this 5-year mark. It's going to be important to continue to see this as things go on.
I see. Thank you very much. And as more data become available, we want longer and longer data. But when do you think we could expect the next report of this trial to come available?
My understanding is that, it gets the key data, sort of the primary outcomes, mortality, major stroke gets reported out every year. The analysis, what we'll do in terms of sort of the deeper dive analysis, we'll start to see it. There's also some discussions about how do we do a better job of capturing patients who have fallen out of the studies. And I think, that's one of the limitations here. We don't have to get into it right away, but, when you have patients who are dropping out of studies, right, they move, they get older, they go somewhere else. It's hard to keep following up every single year for something like this, especially if you're feeling well, or if you've moved, or maybe if you're not feeling well and you don't want to come into the hospital. And so how we adjust things to better capture those patients is going to be important. In this study, we asked sites to try to find out how patients were doing, if they were alive, if there had been complications, but we didn't use some of the other tools that are potentially available. And so that's one of the things we want to look into for future data, to really make sure we're trying, especially as it relates to survival, that we're checking, how are these patients doing, even if they've exited the study.
I see. Thank you. And that's certainly one of the things that we've discussed during the revision process, where Evolut trial is an international site trial, and I think in sort of region-specific difference and difficulties in capturing these longer-term outcomes. So I think that would be a very interesting thing to see you accomplish in the future follow-up. So finally, what should readers take away in perhaps one line from this 5-year outcome, TAVR, SAVR, low-risk patients in Evolut low-risk trial?
Yeah, so I think this is more of a confirming process with this study. Our current ACC guidelines state that, if patients are, over the age of 65 that and have appropriate anatomy, that TAVR should be considered as an alternative to surgery. And the question is, does that make sense for these young patients? And this data says, yeah, it makes sense to have that conversation. Review with the patient, risks and benefits, long-term outcomes, the challenges overcoming, the being out for a couple of months when you have open heart surgery. But I think it's also important to note that these are this isn't all patients, right? This is a group of patients that had anatomy that was appropriate to have the valve replaced. They didn't have bicuspid valves. And they also were patients who had anatomy that was appropriate to have surgery for. And so I think really what this drives home is that if you have a multidisciplinary heart team discussion in a shared decision-making fashion with the patient, that choosing TAVR or SAVR for that patient makes sense and is going to be safe and effective, at least now out to 5 years.
That's perfect. Thank you very much for the great summary. That's all the question I have. So thank you very much, Dr. Forrest, for joining with us today and sharing your insights on this important trial, and congratulations.
Absolutely appreciate it. Thank you for having me.
Thank you.